So with that, I'll welcome everybody, and on the next slide, we'll tee up kind of our core ethos here. And this is really that obesity is a chronic and relapsing disease. We say this every echo. Some folks who participate in our echoes are new to obesity care, and so we always want to kind of center ourselves around the disease of obesity and the core ethos, again, as I mentioned, that this is a chronic and relapsing disease. We are very careful at the OMA to use language such as the patient with obesity versus the obese patient or that such terminology. And again, this is a very safe place to learn, ask questions, those sorts of things. And we're always thrilled to have a subject matter expert in the obesity space across multiple areas of obesity, be it nutrition, be it surgery, be it behavioral health, those sorts of things. So we're always thrilled to ask experts to come and help us host this. This is what our agenda today is going to look like. And so we'll have a brief didactic presentation. We'll answer any questions that you may have of Dr. Jad after his remarks. We'll do a patient case presentation. And then again, anything and everything that folks may want to know, we're here as a collective to help with such matters. So with that, we'll go to the next slide. And I would like to introduce Dr. Ahmed Jad, who is from the north, from Canada, on to our echo today to discuss bariatric procedures. And we'll turn it over to Dr. Jad. Thank you very much.
Thank you so much. Hello, everybody. Again, my name is Ahmed, or Jad, depends on how you like to say my name. Bariatric surgeon here in Canada, trained in the French Canadian provinces. So I mix English and French a little bit, but here we're going to do English only. So basically, the title of my presentation is The Tipping Point When Obesity Needs a Surgical Answer. Next slide, please. So I have no disclosures. Next slide. So the objectives today that I would like to chat about is indications and contraindications of bariatric surgery, types of bariatric surgeries, what are the cons and pros of each surgery or advantage or disadvantage, weight regain after bariatric surgery, and is bariatric surgery safe? Next slide, please. So the indication for bariatric surgery have changed recently in 2022 after the IFSO meeting, which is International Federation of Obesity Surgery. Basically, the BMI patient will be BMI 35 and above, or BMI 30 with comorbidities like diabetes, hypertension, metabolic syndrome. Previous guidelines was talking about BMI more than 35 with comorbidities. Now it's a bit low to 30. So these are the new guidelines. We're talking about extreme ages for indication of obesity. Now we're talking about patient above a certain age for adolescent population, and that will be case by case. Also for elderly patients, we talk about age 65 and above. So those are case by case basis. Now bariatric surgery, talking about bridging to another treatment. Patients who have weight problems, sometimes they are not eligible for joint replacement. So we do bridging with bariatric surgery first. They lose the weight and get the joints done. Same thing with big abdominal hernias. Those patients will have high recurrence rates if they get the surgery while they are morbidly obese. So we do the bridge, the hernia surgery with a sleeve or any kind of surgery that we approve. And then high-risk patients, you have patients with heart failure and NASH. Those we try to case by case, and we try to choose who will be eligible for surgery. Next slide, please. So what are the contraindications of bariatric surgery? There's absolute contraindication that we don't approve patient for surgery, lack of motivation. The patient will have to be motivated and involved in their care. Smoking is also something that has to be patient has to quit smoking before surgery. We talk about 3 months. Some centers talk about 1 month, but where I work, we do 3 months smoking cessation. Active alcohol or drug abuse, active and unstable psychiatric illness. We try to wait until the patient is stable from a psychiatric point of view for a year at least. child B and C cirrhosis. This is another contraindication. And basically, child B and C cirrhosis is a contraindication for any surgery in general, unless it's an emergency. Also, portal hypertension. And if we look at the relative contraindications, we can look at Crohn's disease, like inflammatory bowel disease. We can do sleeve only if there is no foregut involvement of Crohn's. HIV patients, they can get a sleeve as well, but their disease will have to be under good control. Organ transplantation, we don't do malabsorptive surgeries. We do only restrictive, what we will discuss in the next slide, please. So this is a picture of how we do things in the OR. If you look at the patient in the left, you'll find the small, tiny keyhole incisions there in the abdomen. This is basically 5 to 7 incisions for bariatric surgery in general. The picture in the middle is showing you the position of the trocars we use for the surgery. And this is laparoscopic because there's also robotics. And in the right here, this is how we set up the OR for surgery. Next slide, please. So bariatric surgeries, there are two types. The first type is restrictive, meaning that making a space or a volume smaller than normal. We have sleeve gastrectomy. Basically, we take about 70 to 80% of the stomach and we leave a sleeve-like or a banana-shaped stomach. It takes about 60 cc of fluid. And then you have the adjustable gastric band. You have the couple of new techniques. You have the balloon. Basically, patients ingest a balloon and you leave it there to take space in the stomach. Patient will eat less, so you will start losing a bit more weight. And then on the right, you can see the ESG, which is the endoscopic sleeve gastroplasty. This is a technique that's growing currently. Basically, it's a day procedure. Patient come in, have a gastroscope, and through the gastroscope, we imprecate and suture the stomach from inside. Next slide, please. Then we have the more complex surgeries. We call it malabsorptive. You have the Roux-en-Y, which is on the left. This is a bypass surgery. And then you have the PBDDS, which is biliopancreatic diversion, duodenal switch. It's also another malabsorptive surgery. And then you have SADS, which is single anastomosis, duodenal surgery. And then you have OEGP, which is one anastomosis gastric bypass. All of those are malabsorptive because we bypass certain portion of the small bowel, which will decrease the absorption of certain nutrients and eventually will help the patient lose some weight. Next slide, please. So sleeve gastrectomy, we'll talk about each surgery, and the surgeries I'm going to discuss are not all the surgeries that you guys saw in the last two slides. I'm only discussing the surgeries that has long-term data and follow-up that we have scientific evidence about what we are doing. So sleeve gastrectomy, the advantage of this surgery, it restricts the amount of food passing into the stomach. It induces rapid and significant excess weight loss, about 50%. And if you look at the total body weight loss, it can go between 20 and 30%. I find that patients who are younger in age lose more weight. It requires a short hospital stay. Sometimes we do the surgery as a same-day surgery. The patient come in the morning, leave after the surgery. And how it works is basically we change the gut hormones that suppress hunger. So we have the ghrelin hormone. It's present in the fundus of the stomach, and that's removed when we do the surgery. So we reduce appetite, improve satiety. This advantage of the surgery, it's non-reversible. Once you resect the stomach, you can't put it back. It can increase the chances of GERD reflux. Also, there's potential micronutrient deficiency. It's a bit rare because basically we're not bypassing any small bowel. Next slide, please. Then the Roux-en-Y gastric bypass, advantage of this surgery, you have 60 to 80% long-term excess weight loss, slightly more than the sleeve. And if you look at the total body weight loss, I would say 20 to 30, but I would take this up to 35, slightly more than the sleeve. It restricts the amount of food that can be consumed, and it has same effect on the change in the gut hormones to suppress appetite and enhance satiety. And it's associated with good maintenance of more than 50% excess weight loss long term. So what are the disadvantages of this surgery? It's a bit more complex than a sleeve and could result in greater complications. Can lead to long-term vitamin deficiencies as we bypass portion of the duodenum. So you find deficiencies in vitamin B12, iron, calcium, and folate. And it has the patient had to adhere to dietary recommendation, lifelong vitamins, mineral supplements, which, as you remember from the absolute contraindication, patient has to commit to that. Next slide, please. The next surgery that has long-term evidence, which is the PBDDS, which is biliopancreatic duodenal switch. Advantage of the surgery, it has higher weight loss than the Roux-en-Y and the bands and the sleeve, about 60 to 70% excess weight loss at 5-year follow-up, up to 50% of total body weight loss, which is basically double the amount of Roux-en-Y and sleeve, 70% reduction of fat absorption. It has good outcomes for gut hormones and decreased appetite, and it's more effective against patient who has diabetes compared to the other surgeries we discussed. Disadvantage, higher complication rate as it's a complex surgery, greater potential for protein deficiency, long-term deficiencies in vitamins, especially the fat-soluble vitamins, because we are bypassing most of the ileum, we bypass the jejunum, and those are two areas that absorb a lot of those micronutrients. It requires compliance with follow-up care and strict adherence to diet and vitamin supplementation for life. Next slide, please. Now we have the adjustable gastric bands. Advantage of this, it induces excess weight loss, about 40 to 50%. Same thing, 20 to 25% total body weight, a little bit less than the sleeve and the Roux-en-Y. There's no resection, no bypass of any small bowel, short hospital stay, same-day surgery, same as a sleeve. It is reversible, adjustable. You can take the band out. The lowest rate of early post-operative complication and mortality among all the approved bariatric procedures, lower risk of vitamin and mineral deficiencies. However, what are the disadvantages of this procedure? Slower, less early weight loss than other surgical procedures, greater percentage of patients failing to lose at least 50% of excess body weight, possible band slippage, band erosion into the stomach. It's basically a piece of plastic going around the stomach, so that chances of complication higher. And I just want to go to the last piece here, highest rate of reoperation compared to the other surgeries. You find people who have a band, at the end of the day, they will come want the band removed or adjusted. So there's always reoperation in that. We don't do a lot of those in Canada anymore. We do the other ones I discussed. Next slide, please. So what are the major complications of bariatric surgery? I'm comparing again the band with the sleeve, Roux-en-Y, and the switch, because we have long-term data on these surgeries. Mortality, again, is less than 0.1%. 0.1% in sleeve, and then if you go to duodenal switch, 0.3%, which is still a low chance. Early complications, higher in the duodenal switch because it's a more complex surgery. Reoperation rates in the late complication, you find in the gastric band is more than 20%. So that's why it's more and more people moving away from the bands and going the sleeve. Sleeve is basically the most common surgery done in the world right now. I would say 40 to 60% of bariatric cases is sleeves. Next slide, please. What are the early complications when you talk about a patient who come to your office or you see a patient in the hospital less than 30 days? Most frequent causes of readmission, you find food intolerance, nausea, and dehydration, abdominal pain, sepsis and septic shock, bleeding, bowel obstruction, VTEs, and wound infection. Next slide, please. What about the topic of weight regain? Patient can have a surgery and then they have weight regain. So what are the factors affecting the weight regain? You have the preoperative BMI. If the patient have a higher BMI before the surgery, the weight regain will be a bit higher. Operation dependent, it depends on what surgery that was done. Behavior changes in the patient, anatomy of the surgery that happened. And then you find that with the sleeve, the weight regain is a bit higher than the other surgeries compared to Roux-en-Y or duodenal switch. Next slide, please. So weight regain, patient come to you or come to me for weight regain. What we're going to do, so we're going to evaluate compliance. Basically, patient is recommended to be adherent to diet, physical activity, and following the multivitamins and making sure that, they're following the post-op instructions given to them. Nutritionally, the same thing. Patient is making good behavior and good choices with their nutrition. Radiography, basically, we do either CT, X-ray to make sure the anatomy looks okay. Endoscopic, we put a scope in and have a look at the sleeve, make sure the sleeve is not like expanded or like increased in size, make sure the Roux Y, that the connection between the stomach and the jejunum for the Roux Y, the connection is not bigger, which will allow more food to go in. And then what are the options for revisional surgery? Again, it depends on the initial surgery. If you have the intact or altered anatomy, depends on the surgery. The surgery that's quite difficult to reverse or change is the Roux Y. And then it's very important to have options, and that's something we can discuss with questions. Next slide, please. So when do primary care physicians send patient back to the surgeon? If the patient has abdominal pain that's not well controlled, if the patient had food intolerance, which will lead to the next one, which will be malnutrition, and then weight regain. So these are the main things that will bring the patient back to the bariatric surgeon from a primary care physician perspective. Next. So is bariatric surgery safe? So there's the NSQIP data. I'm sure you guys are familiar with it in the US because it's coming from the American College of Surgeons. Basically, it's a National Surgical Quality Improvement Program. We use the same one in the US. We use it here in Canada, and it happened that I'm the lead of that NSQIP data in my hospital. So basically, I did a quick study comparing bariatric surgery to other common surgeries that done at the hospital, including hernias, bowel surgery, joint replacements, appendectomy, hysterectomy. And you can see here with the bariatric group, observed expected ratio is a bit lower than other ones, 0.3. Next slide, please. And if you look at the bariatric group here, you'll find that most of them were female patients, 83%, and that's common everywhere. Most of the bariatric surgery is done in females, less on male. Next slide, please. And if we look at the bariatric group here, we're going to look at the mortality, morbidity, and reoperation rate, cardiac, SSI, which is like surgical site infection, UTI. You'll find the bariatric group, it's almost 0 cases or 1 case maximum, which shows you how safe is this surgery from the data that I collected here in our state or province. We call it here province. So basically, I would say an appendectomy and a cholecystectomy is more risky than a bariatric surgery in some cases. So that shows you how safe is bariatric surgery is. A lot of centers do it as day surgery. Other centers do it as overnight procedure, and patients just go home. And again, as you can see here, the data show that it is a safe surgery. Next. I think that's it, guys. Thank you.
Great. Go to the next slide, if you would. And any questions that anybody has on the call for Dr. Jad about anything he reviewed, or maybe a post-surgical patient that you're managing in your clinic? Any questions from the group? You can come off mute, put it in the chat. I'll just kind of lead with a question, Dr. Jad, for you to kind of weigh in on, knowing that the high propensity of bariatric surgery is with sleeves, as you mentioned, because of recurring reflux issues in those patients postoperatively. Do you see a swing toward gastric bypass away from sleeves and kind of, this preponderance of reflux problems with those patients based on your management of your group?
This is a very good question. In one of the slides, I mentioned one of the disadvantages of a sleeve is acid reflux. Number one, it can basically make a patient who doesn't have acid reflux before a sleeve has acid reflux after the surgery. I think it's about 9 to 10% chance of the patient to get GERD or acid reflux after surgery. Also, some patient who basically have a patient who come to you, takes 1 PPI a day, things are well controlled, and then they get a sleeve. Suddenly they are on 2 a day. Reflux is making them wake up at night. So basically, if a patient come to me with acid reflux already in 2 or BID, PPI, very miserable, unhappy with their quality of life because of acid reflux, I shouldn't give them a sleeve. They should go right away to do a Roux Y. And then if you have a patient who come to me, I did a sleeve, and then the acid reflux make them miserable. They're awake all night. They have to sleep sitting up and all of that stuff. Then probably we can revise the sleeve and switch to Roux-en-Y gastric bypass, and that solve the problem.
Mm-hmm. Do you steer type 2 diabetics more toward a gastric bypass in your clinical management, or sleeve, or depends on the patient, or?
This is a very good question, and people will agree or not agree with you with that point. So a lot of the evidence they have, they talk about, okay, if you have better control of the diabetes, then probably you should steer the patient towards a Roux-en-Y. However, there's a big study that came out of Scandinavia that shows you the difference is almost the same. Like regarding weight loss, maybe the Roux-en-Y a little bit higher, but then if you look at the diabetes and the other comorbidities resolution, that study actually impressively shows you that they're almost close to each other. That's why a lot of people prefer sleeve first, because basically when you do a sleeve, you're not burning any bridges, and you can switch it to something else. Right? So that's a good point. But usually when someone has poorly controlled diabetes on insulin, 2, 3 different drugs, then probably to have a better control, you steer them towards Roux-en-Y. But if it's just the patient is diabetic and you have a bit of control there, then probably a sleeve would be a good start.
Any questions from anybody about any of that, or again, patients you're managing? Okay. All right. Well, let's go to the next slide. We'll jump into our patient case. Before we do that, just we always highlight some resources that the OMA has. Obesity Pillars, as many of you know, is our open access journal. So this is an article here on the clinical practice statement that we published in 2022 on nutrition and evaluation of patients from a surgical perspective. And then the second publication is also in Obesity Pillars as well, looking at risk of recurrent stroke and hospitalization in a surgical patient population. So we've got those links included in this slide deck, which you'll be have access to early next week after this echo session. So please avail yourself to those. On the next slide, we always highlight some resources that we have in the OMA Academy. If you're not familiar with our Academy, that is our learning management system, which is just a treasure trove of all kinds of information across the space of obesity. And here on this slide, you see highlights of various content that we have. We have a very, very high number of CME bearing content in the Academy. So if any of you are on the journey toward seeking ABOM certification, our Academy is a wonderful place to utilize to prep you for the ABOM as well as CME bearing opportunities that you may have as required by your home institutions or the like. So these are just a sample of some lectures that we have in the Academy on metabolic bariatric surgery and some of the elements that Dr. Jad spoke to in his lecture. So on the next slide is a patient case that was submitted by Dr. Pascal Carbonara. Dr. Carbonara is our chair of our Clinicians and Training Committee at OMA, or CIT we call it. And so she works very closely in her institution with residents, medical students, fellows, et cetera. And so this patient case, she's not able to join us today, but this is the narrative of what she submitted about her patient. So we'll click play and then ask for any of you to have input on how you might manage this patient.
You are a primary care physician. You have a 39-year-old Latina patient with a BMI of 38. Her height is 5 feet 9 inches and weight is 257 pounds and is currently taking Wegovy 1.7 milligrams.
At her last appointment with you, her heart rate was 72 and blood pressure was 115/80. You ran some blood tests which came back with her HbA1c at 5.2, ALT at 13, AST at 12. Her total cholesterol was 155, HDL was 52, LDL was 87 and her TSH was 2.71. This patient lives with her family and works full-time. She tries not to cook separate meals for her children, but that is difficult. She does not eat out often, maybe once weekly. She has no help at home, as her husband has MS, so is limited in how much he can assist. She has lost 23 pounds in 3 months on Wegovy. The question becomes how to counsel the patient on nutrition with realistic expectations for long-term success. Thank you for any advice or direction you can point me in. Your input is greatly appreciated.
Okay, so the question that Dr. Harbonara has for the group is, how would we counsel this patient on nutrition? She's obviously got a lot going on at home and care of her husband with a chronic disease. 23 pounds down on Wegovy in 3 months. Anybody want to chime in about this patient as of Latin heritage, about adherence to nutrition? Any thoughts that anybody has about this patient or a similar patient that you may be dealing with in your own clinical practice?
I can start if you want me to.
Yeah, please.
So for this patient, first, I want to actually applaud her for committing to the Wegovy, which is in 1.7. So basically, she started at the 2.25, and she went up with the medication. So she's tolerating the medication. She's able to get the medication, and the medication is working because she lost 33 pounds. Or 23 pounds. I'm not sure what is the percentage of that weight loss from her total weight, but as you know, more than 5-10%, that will show some good effect on the patient. So that's one. Of course, she has a hard time. Husband has MS. She does full time. So the question for her is, we need to know, I will get a diet history from the patient, try to know how many meals she eats a day. Does she skip any meals? And what type of food she eats? Is she taking her multivitamin? Does she have high risk time? Because people usually, when they work full time, they come after work and start eating at night. Basically, what is the percentage of calories she is taking at night, which is can be a problem. So I'm gonna get a good nutrition history from her, know what she eats when she eats. I'll try to see if we can redo certain things, like basically try to have the meals at work with the meal prepping in the weekend if she can do that. Is there a food service that she can use? So that's basically going to be a start point for her, and I'm happy to hear what you guys think.
Any others? Anybody else have suggestions? A thought I have is ensuring high protein orally. That's going to help curb hunger. The other thing that we always have to be mindful of with the use of these very powerful GLP-1s is loss of fat and not loss of muscle. So, ensuring body comp with this patient to make sure that we're losing the right type of weight and not the less, desirable type of weight. Amy says refer to a registered dietitian. Always important in management of patients with the disease of obesity. I think either whether we're talking about a surgical patient or non-surgical patient. So we're seeing a lot of power in these medications. Anyone else have any other ideas? A dietitian would be able to understand the culture and what type of shopping that this patient does, what sort of food preparation. Are you using healthy oils versus oils that aren't healthy, or butter, in the foods that you're making and that sort of thing? Because that could also help cut down on some calories if she has some basic counseling and education on, grabbing things off the shelf that are healthier in her food preparation too, are a couple things that come to mind. Any other thoughts or anyone else? any input on if simple protein shakes are okay to recommend? Dr. Jad, do you have any comments on that protein shake use with your patients or anybody else on the call?
So you brought up a very good point when you mentioned ensuring the patient has protein. Usually I try to make sure the patient has at least 60 to 70 gram of protein a day. Again, it depends on your level of activity. Usually I try to make sure the patient have like real food or that contains protein and supplement a little bit with shakes. But I don't want my patient to depend solely on just protein shakes. Sometimes I do that before surgery to shrink the liver for 2 or 3 weeks, but I don't usually use meal replacement alone, because if we look at the meal replacement alone, that can be a bit dangerous because of the low calorie, and that will require medical attention or medical follow-up. So I try to supplement, yes, with some protein shakes, but the patient will have to consume some sort of protein from food.
I think in a post-surgical patient too, sometimes the dependence on just the protein shakes and those sorts of things can go longer than we want it to. Obviously, they need to advance their diet very carefully after surgery because of swelling and those sorts of things. But then we can find that it's just easier to do that, and I don't want to eat regular foods, right? So kind of getting them back into a healthy routine and away from that, as you're mentioning, exclusive dependence upon the shakes is very important, so they can kind of get back into their normal
So
eating
in our center here, we're a bit more pushy. I have two excellent dietitians with me. Basically, in some programs, they like to keep the patient on like soft diet or liquids for 4 weeks. In our facility here, we push it 2 weeks, and the patient will have to start having some normal texture food, because texture for patient is very important. So we try to focus on that on the patient, and it's been working well, unless the patient has some sort of like metabolic issues, or or like if a patient doesn't have a parathyroid gland, that's another beast, right? But the majority of patients, you try to push them in a nice way that they start like normal foods or texture food in like 2 weeks.
Yeah, agree. Yeah, just a comment, protein shakes are a good option for weight loss to augment the diet. So anybody else have any questions or any tricky patient you're managing in your clinic that you'd like kind of the beehive to weigh in on? Happy to give you any insights. Okay, so I think what we're hearing is involving a dietitian with this patient would be really important in helping her determine some, healthier food choices, really getting a detailed food history from this patient. She's had great response with the Wegovy, and we want her to continue with that. With a BMI of 39, she's headed in the right direction for sure, but I think including a dietitian to really unpack this a lot more based on her busy full-time work and caring for her spouse, to really meet her where she's at, if you will, with this would be kind of a summary of recommendations for this patient is what we're seeing. So, all right, well, let's go on to the next slide. I think we're at that time where we'll be wrapping things up, and thank everybody for participating. As for those of you who have not participated in our ECHO, we offer our ECHO sessions the first Friday of the month at this same time, same place as you see on the slide there. So Friday, May 2nd will be the next ECHO offering. We're always thrilled to get patient cases submitted, and Katie just put that in the chat. So if you've got a patient that's tricky, or you want a lot of folks to kind of help you think through, that's really the beauty of what these ECHO sessions are, is to have everybody kind of scratch their head a little bit and kind of unpack different challenging patient clinical scenarios. So please encourage you to submit a case. It's really easy to do that. And then always want your feedback on our ECHO sessions as well, and improving these and making these better and better as we move forward. So hearing no other questions or no elements in the chat, I want to thank Dr. Jad for being our faculty today and telling us everything about bariatric surgery. Also, just highlighting the OMA annual conference, which is right upon us, as our staff knows. So that will be the end of this month, and still seeking registrations for that as well. And for those of you who may not be able to attend, we do record a good chunk of our lectures at the OMA annual conference. So you'll be able to, a couple months after our conference, be able to view many of our offerings in the OMA Academy, as I mentioned previously. So if you're not able to make it this year, we will be in April of each year is now our annual conference. And then we offer a very truncated meeting in the fall of each year that we call the OMA Summit, which is kind of a weekend meeting. And this fall's focus in October will be obesity and cardiovascular disease. Last year was our first year of offering the OMA Summit, and we focused on obesity and women's health. And so if you have an interest in cardiovascular disease or have colleagues that do as it relates to obesity, we would love to see you at our summit, which will be held outside of Austin, Texas. So stay tuned to our website as the summer gets closer about registration for our fall summit. But want to thank all of you for your attendance today, and especially Dr. Jad, our faculty, and look forward to seeing you, if not at our conference here in a few days, at the next month's ECHO session. And have a great weekend, everyone. Thank you so much.